My topic today is one of the fascinating disorders and difficult to treat disorders of the nervous system, idiopathic intracranial hypertension. Also my subject of interest. I'd like to thank Professor V.G. Ramesh, my teacher at the S12 Madras Institute of Neurology, MIM, for kindling my interest in this subject. We now enter the topic, clinical pearls. These are the related publications from MIM, two by Ramesh sir and one by me and my colleagues. I'll briefly outline the disease per se, and then we'll discuss the clinical or the management pulse. IAH, pseudotumor cerebrae, and benign intracranial hypertension. They have been, all the terminology have been used interchangeably. Idiopathic intracranial hypertension is a more precise term for the disease entity that is not linked to a secondary disorder. The patient presents with signs and symptoms of increased ICP with no demonstrable organic cause in the brain imaging, including venous sinus thrombosis, with normal CSF composition. Dandy was the first to describe and document the CSF pressures and the composition. And he also ruled out the possibility of brain tumors with ventriculography. He did this in as early as 1937 in 22 patients, and he documented it well. His criteria came to be formed as Dandy criteria. They have been revised and modified first by Smith in 1985, and they are signs and symptoms of increased ICP, absence of localized findings on neurologic examination other than 6-nerve palsy, normal neuroradiologic studies, an awake and alert patient with no other cause of ICP present. And the International Classification of Headache Disorders, 3rd edition, International Headache Society defines it as a new headache or a significant worsening of a pre-existing headache caused by and accompanied by other symptoms and or clinical or neuroimaging signs of idiopathic intracranial hypertension with typical features such as it includes the new headache or a pre-existing headache fulfilling the criterion C and B. Both of the following, the idiopathic IAH has been diagnosed with a CSF pressure demonstrated at opening pressure, lumbar CSF opening pressure demonstrated to be more than 250 millimeters of CSF or 280 in obese children, with either or both of the following, that a headache has developed or significantly worsened in the temporal relation to idiopathic intracranial hypertension, or that had led to its discovery, or a headache that is accompanied by pulsatile tinnitus and or papilledema. The pathophysiology of idiopathic intracranial, as the name goes, it is unclear. A commonly accepted pathophysiology is a dysregulation of CSF dynamics. Cerebral venous sinus narrowing has been proposed, but two schools of thought, whether it is cause or effect, is still going on. Obesity is grossly associated with the majority of people with IAH. Mostly they are women of childbearing age, though a direct causal role is not known or established beyond doubt. Some say it is autoimmune cause. Vitamin A, tetracycline, amiodarone, oral contraceptive pills, cyclosporin, cytarabine, growth hormone, isotretinoin, levothyroxine, lithium, and acute change of steroid use have all been postulated to be the cause for idiopathic intracranial hypertension, though they come to be classified as a secondary pseudotumor cerebrae syndrome since their use has been associated with the development of the disease rather than idiopathic. And the symptoms may be headaches. They are present in more than 84% of the people. They can be non-specific and varying in type, varying in location, varying in frequency. There can be transient visual obscurations, have been demonstrated in more than 68% of persons with IAH, especially lasting a few seconds and related to orthostatic movements. And pulse synchronous tinnitus is seen in about half of the patients. Subjective visual loss is seen in about a third of the patients. Horizontal diplopia in 18% of people, demonstrating sixth nerve palsy, and papilledema, that is bilateral disc edema due to ICP, is an important finding. Rarely, the classic symptoms of ICP who present with asymmetric papilledema with one optic nerve edematous and the other one less or so, or not at all, have also been demonstrated. The examination, visual acuity is usually normal at presentation. Diplopia is present and it indicates sixth nerve involvement. Fundus shows papilledema that can be bilateral, asymmetric, or normal. The fields are assessed by Goldman or automated perimetry. Demonstrates enlarged blind spot with peripheral field constriction depending on the disease progression. Optical coherence tomography has been used to assess the retinal nerve fiber layer thickness, total retinal thickness, optic nerve head volume, and retinal ganglion cell layer. It is useful for follow-up, though it is not useful for prognostication. The diagnosis is based on neuroimaging to rule out intracranial mass. That is the first line we have to adopt when a patient presents with increased ICP symptoms and signs. The lumbar puncture and lateral decubitus position to confirm the elevated opening pressure, and the CSF analysis to prove its normal constituents. And then an MRI with MR venogram to rule out venous sinus thrombosis. These are some of the findings seen in MRI. The tortuosity of optic nerve sheath, the distension of optic nerve sheath. There can be partial empty stella and transverse sinus that can be found to be stenosed, though it's still debated whether it is a cause or effect. The management goal is to preserve the optic nerve function while managing the increased intracranial pressure. The idea is to treat the underlying disease like obesity, protect the vision, and minimize the morbidity due to headache. What are the pharmacological therapies available? Acetazolamide is the first line therapy. As a result of a randomized controlled clinical trial, IAHTT, it has been found to be lowering the ICP and improving the visual function. Furosemide or topiramate are the second line agents, and the primary headache prophylaxis along with topiramate and other lesser NSAIDs are the mainstay of pharmacological therapy. Corticosteroids are indicated only in a short-term basis in patients presenting with marked visual loss at presentation. What are the options of surgical intervention available? Surgery is considered only when the patient's vision deteriorates in spite of maximal medical therapy. They are optic nerve sheath penetration, CSF diversion, lumboperitoneal or ventriculoperitoneal shunt, intracranial venous sinus stenting if MRV shows stenosis of dural venous sinus system. Optic nerve sheath fenestration, the limitations include additional CSF diversion may be required after the procedure. Complications includes direct optic nerve injury, traumatic optic neuropathy, retinal vascular occlusion. And it is safe and successful only at experienced hands. CSF diversion is commonly employed after initial improvement. The patients still report persistent or recurrent headache, overdrainage, shunt blockage, infection, abdominal back pain, intracranial hypotension, tonsillar herniation, etc., are certain complications of the procedure. And the revision has been recorded to be required in more than half of the patients, and multiple revisions have been recorded in a third of the patients who have undergone the CSF diversion procedures. What is the prognosis? Prognosis for visual loss varies considerably in different series reported. Early reports suggested fewer than 25% had functionally significant blindness. Of late, the figure is said to be rising. Some degree of visual loss has been demonstrated in more than 96% of people by Goldman perimetry, as reported by Wall and George. The IAH treatment trial that concluded, it reports in 2014, the three most important negative risk factors for poor prognosis related to progressive visual field loss were male gender, high-grade papilledema at presentation, and decreased visual acuity at baseline. Well, we now move on to the practical considerations. It's quite a difficult disease to diagnose and treat. How to confirm the diagnosis? The mainstay is clinical examination with the recording of headache pattern, a change in headache pattern, fundus and field testing with or without the employment of optical coherence tomogram, MRI and MRV, and the most important onset. The patient must be comfortable. The patient must be comfortable. There should be no valsalva maneuver or talking or crying that are likely to increase the intra-abdominal pressure. Straightening the patient's leg at the hips to avoid compressing the abdomen. The column of CSF in the manometer needs to be sufficient time to settle. After settlement, small oscillations with breathing to be observed. CSF pressure varies diurnally, so one recording may not be representative. When the clinical findings are not in line with the opening pressure, that is, when the pressures are normal or less, and we have a high degree of clinical suspicion of idiopathic intracranial hypertension, it is said that the pressure values are likely to be calculated wrongly and the LP has to be repeated. And a guarded drainage of about 20 ml is beneficial, though there has been no recommendation or consensus or prognostication as regards the volume that has been drained. And at this juncture, I would like to mention about the usefulness of the method devised at our institute, the amine method, modified Marmarou's method of bolus saline injection, the devised by our teacher, Professor VGR. The brief procedure is: patient is in the right lateral position, lumbar puncture is done with 20 G needle under local anesthesia. The needle is connected to a saline manometer through a three-way adapter without letting any CSF. The patient is allowed to relax, extend the lower limbs and neck, and lies comfortably in the right lateral position. The opening pressure is noted. Pressure is noted in centimeters of water after the saline column stabilizes. And an important estimation based on this method is the Rout, the resistance to outflow of CSF, which reflects the compliance of the system. The amount of fluid that can be accommodated without a rise in the pressure is the compliance of the system. So a known volume of saline, usually 5 ml, is injected into the subarachnoid space at the rate of 1 ml per second through the three-way port. The peak pressure is reached after the bolus injection is noted. The saline column falls gradually after reaching the peak. The rate of fall in pressure reflects the compliance of the system. If the system takes a longer time to bring back the pressure to normal, the compliance is less, and so on. And it is calculated as Rout, the resistance to outflow of CSF. How does this benefit us, the clinicians? It has helped in diagnosing IAH in those patients who had near normal opening pressure, who would otherwise been left out of the diagnosis of IAH. In our series of about 50 patients, more than 70% of the patients with opening pressure less than 25 centimeters of water had a raised Rout value. How does a single LP contribute to symptom relief? We often find patients reporting significant improvement in their symptoms and signs following lumbar puncture. How is this possible? With the CSF protection rate making complete turnover in about 4 times in 24 hours, and the long-standing changes that cannot be easily considered as a long-term effect of fluid removal. The single lumbar puncture is said to alter the pressure switch, and it alters the balance states to a lower level and sets the venous pressure alarm at a lower level. Is the reason for the improvement following single lumbar puncture. The diagnostic lumbar puncture, it doubles up as a therapeutic lumbar puncture. How is it possible? It is probable that the pressure on the subarachnoid space of the side of the dura keeps the lumbar puncture hole patent and behaves low volume shunt, draining the CSF to the epidural space. The slow of the CSF probably results in the improvement in symptoms of the patient, and the patency of the hole is maintained till the pressure on both sides is equilibrated. What is the dosage of acetazolamide which we commonly prescribe for IAH? We see many of the neurologists and many of our colleagues also prescribing lower doses of 250 milligram twice or thrice daily. It is ideal to start with 1 gram per day in divided doses. It can go up to 4 gram per day, and the safety and efficacy profile has been established by the IAH treatment trial. There is a risk of diarrhea, dysgeusia, fatigue, nausea, paresthesia, tinnitus, vomiting, depression, and rarely renal stones in susceptible individuals have all been demonstrated, but they do not seem to be so serious as to stop any medication. And patient education in this regard is useful. We must encourage them to take a lot of oral fluids and potassium containing fluids like tender coconut water and fruits like bananas and citrus fruits to offset the side effects due to hypokalemia. What is the use of topiramate? It has a similar efficacy as a carbonic anhydrase inhibitor. It is started with a dose of 25 milligram twice daily, and it escalated to weekly twice of 50 milligram dosage. The caution to be patient established in patients, female patients taking oral contraceptive pills because it reduces the efficacy of OCPs. Depression and cognitive slowing have been demonstrated, and it has been known to be teratogenic, and it has been used with caution in patients with childbearing age. What is the option when there is imminent visual loss? When there is imminent visual loss, surgery is the only option to be considered. We may employ lumbar drain temporarily until the surgery is planned. Optic nerve sheath fenestration is good in experienced hands. CSF diversion, lumboperitoneal or ventriculoperitoneal is commonly employed. Neuronavigation may be required for ventricular peritoneal shunt due to the slit-like ventricles. Adjustable valves or anti-gravity or anti-siphon devices reduce the risk of low-pressure headaches. How do you manage the headache? Acetazolamide alone may not be adequate for the headache. In addition to acetazolamide, we may have to prescribe paracetamol or any other NSAID. Indomethacin has a role in ICP reduction and hence found to be useful. And it is important to educate the patients to prevent medication overuse, headache. What is IAH-WOP? IAH without papilledema. What are all the management considerations? Weight reduction as a baseline management. It is otherwise essentially the same as IAH. Acetazolamide is indicated. Headache medications. Surgery may not be considered, may not be necessary or essential. What are all the follow-up tools available? Most of the patients experience remission in about 6 months, and tapering acetazolamide may be considered. Visual acuity, field charting by Goldman or automated perimetry, fundus examination, experienced hands and recording with the fundus photograph, and OCT are all useful tools in managing and following up such cases. With this, I conclude. I thank the organizers for the opportunity.
Hello, Dr. Mahesh. It's a very nice presentation.
Thank you, sir.
I think in the IH, just put in a nutshell, you have covered a very vast areas, right, from the introduction etiology to the various aspects. One of the things I want to share with you is like, I have seen patients improving with a single lumbar puncture. Actually, there's a patient who's a homeopathy doctor who got admitted with papilledema and severe headache, stressing, and with a single LP, we showed a shunt pressure of over 25 to 28 centimeter water. Subsequently, the headache totally disappeared. So she was admitted for a LP shunt, and so we postponed it for a couple of weeks. And she came back after about 3 months, no headache.
Yes.
No diamox, no headache.
Yes.
Then went for 6 months follow-up. Never had happened. So that's one of those patients, as you said rightly, the puncture hole of the needle probably serves as a small shunt, and the needle is getting absorbed in the planes, the facial or muscle planes, and she's totally devoid of the problem at all. And she went for a ophthalmology examination later where there's no papillary at all. It's one of those things as an experience of a few years back, we had the same thing. I don't know many people would have had such similar.
Yes, sir. Our institutional experience proves your statement, sir. Many patients they do dramatically improve with single shunt, and probably it acts as a single LP. I'm sorry, single LP that also doubles up as a therapeutic event, sir, and it avoids surgery in many of the cases and complications associated with the surgery. And
also for a simple mnemonic like for the PGs and so on, like female fertile fat flatulent in 40s. These criteria, this really fits in for IH also. It's one of the criteria. And so with these things, I just keep the floor open for any discussion, any questions. Please.
Sir, we will have the discussion at the end of the program, sir. Now we will go to the second speaker, sir.
Okay, if it's okay, fine.
Yes, sir. Second speaker will be Professor Dr. John Christopher. He is going to talk about the pragmatic approach for the brainstem death certification. Before that, I want to tell that those who have joined late, you please enter your name in the chat box along with the Tamil Nadu Medical Council registration number with your mail ID and your WhatsApp number. Dr. John Christopher is an associate professor in the Department of Neurosurgery, Tirunelveli Medical College, Tirunelveli. He is going to give a talk about the pragmatic approach of the brainstem certification. Welcome you, Dr. John Christopher, sir.
Thank you, sir. And I'm happy to be a part of the new venture. And my thanks to President Arun Kumar sir, and Secretary Rajesh Babu sir, and especially Veera Pandian sir, who is active in coordinating this. And just to okay. So see, this is not a big issue as such. If you see certificating a death is not a major technical aspect as we may think, but recent days this we have to do everything in accordance to the law and guidelines we have been provided. So we have to go through it, and we have to be more legally. We have to be more susceptible. We have to stand the legal scrutiny in court of law. Everything. Recently, we may be seeing so many issues in social media regarding the surrogacy law. Everyone discussing surrogacy law. but many of the doctors don't know what is surrogacy. Few months back, some discussion going on about Assisted Reproduction Technology Act, and many hospitals got closed because of not complying with the law. So this also a recent advance issue where we are following. We have to follow Court of Act which was passed, which is existing in India and which is allowed in Tamil Nadu. So recently in our medical college, I did able to do train test certificate, Brainstem test certification. During that time, I am able to see a lot of ignorance among doctors also. So I want to just, especially so many PGs are around. So why it is important now? So as a neurosurgeon, when we are treating in ICU, some patient relatives will come and demand, please make arrangements to donate our relatives' organs. So that in that case we cannot refuse or we cannot ignore it. So that if we ignore also, it will become an issue. And in future, neurosurgeons going to be work in various centers that are approved for organ retrieval or transplantation centers. So that also we have to be aware of all those things, and we constantly motivated by our higher officials, how many cases you have done like that. So for that also we should know what we have to do, what we should not do, and we should not just follow what our seniors do or what our neighbor other institute do. We should do what Act actually suggested. So also so many patients, for example, when we did a brain test declaration in Tirunelveli Medical College last month, 2 cases, and both patients who received the kidney immediately on the table itself, they started passing urine, and so many patients, poor patient getting organs because of this act. Okay. So death concept. For that, this is initially usually do conventional concept, that is loss of all vital signs. But as medical technology improves, we are now able to sustain the patient, even though patient go into irreversible trauma, we are able to sustain. So in this period, we can use for organ harvesting. That is the idea of the concept act which was implemented in our country. Patient whose cardiopulmonary status has been restored but remain profoundly persistently unconscious and unresponsive. So these cases we regularly see in head injury ICU. So now comes the brain death concept. Brain death concept mainly neurological based. So we a neurosurgeon and neurologist will take a central stage here. So whether we are at the head of the team or whether we are part of the team, we should know each and every aspect of the guidelines. Because suppose any untoward incident happens or any inquiry happens, everyone will come into scrutiny. So we can't just ignore and put signature wherever we have to put. We should know each and everything going in accordance to law and all, that we have to be very vigilant, and we have to be cautious but confident. So that we can easily manage all these situations. First such guidelines were advanced by a committee at Harvard Medical School in 1968 itself, and these guidelines differ in some aspects in different countries around the world. Each and every country have their own small variations, and growing worldwide acceptance of brain death over next few decades happening, as we can see now in India also. It is there is large acceptance, not only among from government side, from patient side, relative side. They are more voluntarily coming for organ donation. Even without our initiation, they are coming and forcing us to do. So what is the concept of brain death in India? Bill was passed in Parliament in 1992. That is, THO Act, that is Transplantation of Human Organ Act. That was passed as an act in 1994. In India, it is a brainstem death, and it is not brain death. So, which is the legal requirement. Essentially, this essentially followed by UK criteria. The brainstem death criteria is followed in UK and some other countries. In US and some other countries, they follow brain death criteria. That is irreversible cessation of entire brain. Whereas in India and other UK and other countries, we follow brainstem dysfunction, not entire. We don't need to wait for entire brain to go into cessation. So this is a diagrammatic representation of irreversible damage of brainstem, and this is brainstem alone. This, essentially, this is almost equal to brain death only. Once the brainstem gone, everything is irreversible only. So that's why this concept is almost equal to brain death. So what is consciousness? Just 1 or 2 slides about basics. Consciousness is an arousable. It is a primitive function, like sleep, wake, and it is one of the basic primitive function which located in the hindbrain, and it is in the deep brain nuclei, medial thalamic nuclei, and cognition part, that is by cerebral cortex and major subcortical nuclei. So what is the anatomy of consciousness, where we can actually locate the part of the central nervous system where the consciousness is located. So it is a reticular activating system, that is anatomy of consciousness. Okay. It acts as an main factor for maintaining consciousness through ascending reticular activating system, and it receives collaterals from ascending spinothalamic tract and project into cerebral cortex and hypothalamus. Hypothalamus is also part of anatomy of consciousness. So now we have to we should know what act and guideline is actually there. So if you, this is a screenshot which I took it from my mobile. Everyone can easily go to the Transplant website, and you can see the acts and orders. Acts and orders, that transplantation of the entire everything is there. That central government act is there. Then Tamil Nadu government orders, whatever the orders given by Tamil Nadu government, everything is there. So if you, I already went through everything, and I took what are the main things and put it in this slide. So you can also go and verify, and you can read it fully. All are 1 or 2 pages only, not a big elaborate thing. This act will have around 20 pages, which include everything, including the punishment. If you have done anything wrong, or if you are not following the guidelines, you may be punished up to 55 years, and all these things are there. So before we get into some controversy, we have to be careful, and while implementing these things, we have to be carefully do, and like surrogacy law and assisted reproduction technology act, so many problems happening around. So we should be careful. We should not go into that sorry state. Okay, the Transplantation of Human Organ Act 1994. It just go through and read it. If you are going to do it, you have to read at least once. And this then various GOs issued by Tamil Nadu government based on the central government act. So everything accordance with that central government act only, but they give certain guidelines by the state government. This GO number 6, they made mandatory for brainstem death. So you can't refuse that. I won't do it. I am ignorant of brainstem death. I can't certify. You can't be. You can't refuse just like that. You can refuse based on the medical or clinical condition. Not you can't just like that. You can refuse, because So Tamil Nadu GO says it is mandatory. So if there is an ideal situation, ideal medical or clinical situation, you have to do brainstem death declaration, brainstem death certification. Whether we are harvesting organ or not is a different issue. You have to do brainstem death certification. That is mandated by the government GO number 6 and GO number 75. It mainly states that DMS is an appropriate authority for all those things. So any private hospital, medical college or GH or wherever the center is there, this DMS is the appropriate authority, and they will impanel the doctors list, and they will recognize the centers. What are the types of centers? Whether it is meant for only organ harvesting, or whether it is for organ harvesting as well as transplant centers. All these things done by this appropriate authority, that is DMS. And GO 289 states that GO brings in another terminology, that non-transplant organ retrieval centers. Even a 25-bedded hospital can be converted into non-transplant organ retrieval centers. So that is the another GO by Tamil Nadu government. So coming back to this TOW Act 1994, so it defines the what is brain death and formalize the brain death certification. What are the preconditions, personals who are the committee members to be involved? What are the protocols we have to follow? What are the time scale we have to follow? All these things are in this act. And it is very simple only. It is not complicated. There is a form 10 is there. Everything will be there. Self-description, descriptive. So you have to just read and write. That's all. It is not a big issue. So there is an amendment to it also happened in 2011. So in that amendment, they included tissue also. Tissues like cornea, not only vital organs transplant. They included tissues like cornea, tendons, heart valves, veins, skin, musculoskeletal nerves, even bone marrow, everything. So previously there were some separate act for cornea and other things like that. So they all repealed that act and they brought everything under this act. So act that transplantation of human organ and tissue act from 2011. So how to certify brain death? This is form number 10 will be there. That is the one and only form we are bothered about. So all these things will, everything everything required will be self-discriminatory from there. Just you have to fill it up. And main thing is that we should even if you are a signatory in that, if you are a part of that committee, expert committee, that is 4-member committee, you should make sure that all the numbers 1, 2, 3, 4 members are in accordance to this act. This is very, very important. So if there is any issue, any problem in this thing, and if somebody goes to court of the law, then no one can defend us. So these things you have to be very careful. Number 1 should be a medical administrator, that is RMO, medical superintendent, ARMO, duty, CMO, anyone. He need not be a impaneled member. Number 1, he doesn't need to be a impaneled member. So number 2 is always an authorized specialist, mostly anesthetist, who is maintaining the case, or even physician or surgeon. But this specialist should be approved by DMS. He should be once approved by DMS, they will give a number, just like a medical council registration number. They will give a number. So we have to, these specialists should sign and put the approval impanel number also along with the signature. And third comes our territory, that is neurologist or neurosurgeon. This whoever signing here also should be approved by DMS, and they should have an impanel number. So 2 and 3 should be impaneled. And number 4 is a medical officer treating doctor, any duty doctor can sign, need not be an impanel member. So among the 4, 2 should be impaneled, and third should be a this order also should be maintained. So this is the Form 10, and you can see everything is written there in word by word. You can just read and just fill it up. So it is not a big thing, and you record all those things in your regular case file also in your hospital, so that you can suppose regular case sheet notes also, you can write all those details, whatever test or whatever procedures you are doing in this form, you have to write it there also. So these are all the guidelines that given in this Form 10. That is what I am taken out separately. All these things, regular patient details will be there, and then diagnosis, whether we have to diagnose what is the risk normal, and mostly in nowadays this trauma, head injury head injury cases are ideal cases for organ retrieval, because other cases, any infection or metabolic case, it is very organs will not be as healthy as these head injury cases. So head injury cases are most acceptable. Even immediately the transplant people also accepting it. Every hospital will nowadays approved central will have a grief counselor. All these activities, the communicating with the transplant and all these things will be done by grief counselor. So we don't need to take part into, don't need to unnecessarily get into do that politics also. Just all these things will be taken care of by grief counselor, and grief counselor is an essential part in according to Act also. So make sure somebody is there to do all these things. Doctor should not do intelligent all these things. Communicate. There is an app called Video Lab. That is what the grief counselor use, and they will upload all those clinical data, ventilator settings, ABG results, everything they will upload in Video Lab, and they will be get scrutinized by transplant people, and that will be distributed throughout the region. First regional regional center, that is Roto, then states Soto, then a national level Noto. Everybody will get access to that data, and whoever have is in the priority list number 1, they will take away the organ. And if some senior refuse, then next to the senior will take the organ. That is the setup. That and all will be taken care of other set, and we don't need to bother about that. And these are the preconditions, and all this data will be in that Form 10 itself. So you just you have to make sure interaction, no, everything has to be, you have to strike out that inside. And one special test we do is apnea test. That apnea test interval should be at least you have to do 2 interval apnea tests. That minimum 6 hours should be there in between the gap. And general, we all these things we know, we daily doing all these things. We GC3 patients, what are the things we have to look for? That is what they have written in that Form 10. And session of spontaneous, there should not be any spontaneous effort in ventilator, and people says all these things. So regular pupillary reflex, how we do, and also movement. Basically all these tests checking the brainstem function from the midbrain to medulla. Each and every part, various cranial nerve nuclei are there. Just by examining cranial nerve function, you can rule out the brainstem function. You can assess the brainstem function itself. Coronary reflex, motor response in the cranial nerve distribution area. You don't need to bother about the limb or trunk. So cranial nerve distribution, motor function, there is no response that we have to make sure. Gag reflex, cough reflex, eye movements on calorie testing, and this apnea test. Apnea test is not just we are making sure that patient goes into adequate hypercapnia, so that we can make sure there is no apnea, there is no respiratory attempt. That is the concept of apnea test. So for that, what we will do, first prerequisite, the patient should have BP should be maintained well, and there should not be any hypothermia. There is the U volemia should be there, and PaCO2, and you have to take ABG also to assess the PaCO2 level, and any other cause for hypoxia we have to rule out, and all these things. And usually the first apnea test should be done at least 4 hours after the onset of coma. That is, suppose patient is coming at GCS3, you should not immediately start doing first apnea test. You have to wait for 4 hours. Or anytime patient goes into GCS3, then you can wait for 4 hours and then you can start apnea test. So apnea test is in anoxic brain injury, it should be 12 hours after the onset of coma. All these are in the accordance to the Transplantation of Human Organ Act. Physician responsible for certification should be available. That number 2 and 3 should be available for apnea test. Ideally, everyone needs all the 4 available is better. Pre-oxygenation should be, we have to pre-oxygenate the patient with 100% oxygen 15 minutes before the onset of apnea test. And we have to do one ABG. Then we have to verify, we have to record all those values. All these values we have to upload in video lab also. So first pre-test and post-test ABG values, everything we have to. Then we are starting the apnea test by disconnecting the patient from the ventilator. Just disconnect it and just preserve the oxygenation by putting an oxygen catheter into the endotracheal tube. Just in case. So, and we have to look closely for the respiratory movements. At least 3 months. This apnea test should be at least 3 minutes or up to 3 to 8 minutes. That is what the law says. So we have to look all these things we have to record in our Form 10 or in case files also. And after after that we can reconnect the ventilator. Then we have to do another ABG and we have to check PaCO2 value, and respiration is dependent on abdominal or chest or may include a brief gas. Nothing, no such movement should be there, so that we can say it is a positive apnea test. If there is any hypotension or cardiac arrhythmia occurs, just abort it and wait, just continue resuscitation and wait. We can postpone the apnea test. Or abort if the saturation is falling rapidly below 85%. In both of my case, while I am doing after pre-oxygenation, it didn't fall below 98 at all. So from 100, it just gone to 98. So it may happen rarely, I think. So in my case, we maintained the BP and high temperature by giving adrenaline infusion. All the noradrenaline, nitroprusside, everything we tried, but in many cases we couldn't do it. But adrenaline infusion, this old technique worked out very well for me. So just a clue in case if you want, you can also try. A brief adrenaline infusion. Suddenly it picked up, BP picked up, and temperature also came back to normal. So interpretation of apnea test. This it will be, we have to write in Form 10, positive, that is no respiratory movement. Negative means respiratory movement present means negative. You can't do any brainstem test certification for a negative patient. Indeterminate, you have to, that is ABG values not accordance to the law. Then you can repeat the test. All these ancillary tests are all there, but these are all not mandatory. Electroencephalogram, maybe it's electrocerebral science. Maybe it may be mandatory test in US, like states where they certify for brain death, not brainstem death. Maybe there it may be mandatory. Cerebral angiogram, all these are not essential. Technician MR angiography, transcranial ultrasonography, somatosensory work. So, in conclusion, Brainstem certification is done to avoid unnecessary prolongation of treatment. It does so that Brainstem certification is not just for organ harvesting alone. It can be you can do Brainstem certification so that you can preserve your ICU resources. That in that act it was also a point. So you don't need to compulsory remove. You have to do organ harvesting. You can just do Brainstem certification and you can take up the ventilator and use the resource for another useful needed patient. Secondly, it done so that organ may be retrieved. So organ retrieval is a one point, and valuable resource maintenance also one point. And it is crucial that no individual is mistakenly diagnosed as brain dead prematurely. That we all take care of. But that we do it, but we have to do it in accordance to law, and all our records, everything should be in accordance to law. That is very crucial. And we have to strictly adhere to the protocol. We should not just because our superior is saying you can use non-impaneled doctors, and you can later on you can get impaneled. That also some superiors will say that, but you should not follow that. Retrospective empanelment may not be stand legal scrutiny, so you have to be careful with that. And transparency. And no, it is important, no member of transplant team should be involved in Brainstem death certification. Suppose a anesthetist is involved in Brainstem death certification, he should not go and do anesthesia in organ harvesting procedure. So that is also very, very important. And no transplant team members like nephrology, urology, or cardiology, or cardiothoracic, no one should be part of this Brainstem declaration certification team. Thank you.
Thank you, Dr. John, for the nice presentation.
Yes, sir.
We, as Dr. Rajesh, Secretary said, we'll have the discussions at the end. So we move on to the next section.
Once again, I request all the members who are participants, please enter your name, your email ID, your registration number, whichever medical council it may be, and then your WhatsApp number, because some of the people are not putting their email IDs, because only when everything is there, you will be able to get the certification. And now we will have the first question for our postgraduate students from the first speaker. It will be on the screen now, and you can start answering in the chat box, and based on your answers, and who comes first only will be given the prize for this question. Only one prize only will be given for each question. And the first question: what is the maximum tolerated dose of acetazolamide? What is the maximum tolerated dose of acetazolamide?
Only for postgraduates or for everyone?
Everyone can answer, sir. No problem. Anyone can answer.
No, sir.
We will avoid. No problem, sir. Maximum tolerated dose of acetazolamide. Okay, the next speaker will be Dr. Selvamuthu Kumaran. He is going to talk about awake craniotomy. Dr. Selvamuthu Kumaran has done his MCH neurosurgery from MMC, and presently he is the HOD of the Department of the Neurosurgery, Madurai Meenachi Hospital, Madurai. I request Dr. Selvamuthu Kumaran to start his address. Selva, your audio is not coming.
Now,
Hi, talk. Your audio is not coming.
oh, Varum. Okay. Good evening, respected President Dr. Arun Kumar, Secretary Dr. Rajesh Babu, other office members of TANS, and my dear friends. Today I'm going to talk about awake craniotomy. When we say awake craniotomy, we become excited because we are going to do a surgery on the patient, and the patient is fully awake, and we are going to talk to him, and we make him do all the movements to speak to him. So it is really exciting. Not only is it exciting for the neurosurgeons, it is exciting for the other doctors too. Probably if you post in Instagram or Facebook that I've done a right frontal glioma, probably you will have 2-3 likes. But if you say and you post the Instagram or Facebook that you are doing an craniotomy, and while doing the craniotomy, the patient is reading a book or playing a guitar, then probably you may have 100 likes. So it is exciting for the fellow doctors also. And also for the public. Again, if you operate and say while operating on a brain, the patient is playing guitar, probably some newspapers will publish it. So it is exciting not only for the surgeon, but also for others. So it is really an exciting topic. So history, we know even thousands of years before craniotomy has been done, because we have heard history of trepanation syndrome, trepanation craniotomy done 1,000 years back. So those were periods where there was no anesthesia. So awake craniotomy was there 1,000 of years before. But scientifically speaking, the awake craniotomy started in 1886, where Sir Victor Orsley first did a cortical stimulation in a patient with epilepsy. He stimulated certain areas in brain, especially in one case, stimulated the thumb area and found he had a focal seizures. So when the stimulated that area, the patient had a focal seizure of the thumb. So he removed that area. So scientifically, this is the first awake craniotomy, and it was done for a seizure. And this was expanded by Penfield in 1926, where by repeated stimulation with an animal experiments, he found the homunculus, cerebral homunculus he found. And he also used it for seizure. He found that there is a correlation in epilepsy. So when certain areas are stimulated, epilepsy occurs. And also there is a correlation between aura and epilepsy. So he will stimulate an area and he will ask the patient whether he experiences aura. So once the patient says he experiences aura, then he will go and remove that area. So this way he started the awake craniotomy. But very surprising to note that awake craniotomy came to India very later. Only in 1990s, awake craniotomy has been at least published, because in 1998, Professor B.K. Mishra did the first awake craniotomy again for an epilepsy patient in 1988. So this is in short history about awake craniotomy. So where to do? So initially, as I already told, it was started for epilepsy, to find a localized epilepsy, to find the site of epilepsy and remove that. But nowadays, it has been expanded to many areas, and especially it is used in tumors in the eloquent areas of brain, motor and language cortex. Especially what we do is, we usually operate awake craniotomy only for patients who is having a lesion in the motor or a sensory cortex. As already told, seizure is another indication DBS, direct brain biopsy, or other indications for awake craniotomy. But awake craniotomy cannot be done in all the patients. The patient is very, very important. The patient's consent is very, very important. The patient refuses, then it is an absolute contraindications. There are other relative contraindications. First is a neurological. When the patient is already dysphasic, then there is no point in proceeding with awake. The patient is confused, irritable, then also awake craniotomy is contraindicated. A psychiatric patient also is a relative contraindications. Sometimes in an obese patient or a patient with obstructive sleep apnea, awake craniotomy may be difficult because when you have to sedate a patient, sometimes they may go for airway compromise and they may go for complications. So in these patients also, the awake craniotomy is contraindicated. And in certain large or very vascular tumors, again, better to be careful in selecting awake, though it can be done, but we should be careful in selecting this patient. Again, cranial, middle cranial fossa lesion or anterior cranial fossa skull-based lesions, again, better to avoid because the dura is pain sensitive. So this may cause pain for the patient. So all these, there are relative contraindications. So why we should do an awake craniotomy? Here, as I already told, the patient is fully awake and is going to follow our commands, not our commands or anesthetist commands. So while during surgery, we know that we are not going to damage anything. So when damage occurs, then we can stop. Either we can go again or go to a different place and operate. So we know that we are not producing damage immediately. And once we do an awake craniotomy, the shorter hospitalization, and also if you know that we are not producing any damage to the patient, then we can remove more tumor. So gross total excision rate may be better in an awake craniotomy rather than in an anesthetized patient. And so once if you do a good resection, the survival also improves. For anesthetic aspect, the advantages are, so we are not intubating the patient, especially in awake or MAC, monitor anesthesia care. So the complications related to endotracheal tube and complicated relation to the mechanical ventilations are all not there. So definitely the surgical complications and anesthetic complications are less in awake craniotomy. So what you do in these patients, so how to go about when you go planning for an awake craniotomy. The most important thing is the pre-operative evaluation. This is one most thing, important thing. If you do it correctly, then 78% of the work is over. So the anesthetist and the surgeon has to sit and talk with the patient. Especially the anesthetist role is very, very, very important. The anesthetist should have a good rapport with the patient because he is the one who is going to talk to the patient throughout the surgery. So a good rapport between the anesthetist and the surgeon is very, very important. So for that, the anesthetist and the surgeon both should sit and talk to the patients, what we are going to do, what the incision is that, what is the duration of the surgery. And most importantly, we should talk to the patient and tell the patients that during surgery, a lot of sound will be heard. In our experience, we have found that the drill sound was the most important, the most fearful thing most of the patients had. The sound of the drill, the sound of the bipolar. Bipolar also we can reduce the sound, but the drill sound, this was the most of the patients, they felt discomfort for this drill sound. So pre-operatively, we should teach the patient that these sounds will be here and nothing to worry about. Some papers say that we can tell the patient to just lie down in the ward for 2 hours and just give training to them. We don't do that. But we, as a surgeon and anesthetist, sit with the patient and teach the patient and tell the patient everything, the pros, cons, what we are going to do, and what sound will be heard in theater. And this will do a very good for the awake craniotomy. So after the pre-surgical or pre-operative evaluation, before shifting to theater, what we do is a topical local anesthetic cream. We have what is known as a MLAC cream, which is a combination of 2 local anesthesia. So this we apply 2 hours before shifting the patient. And once we shift to the patient, we do scalp block and pin site infiltration. For scalp block, we use a local anesthesia cocktail. The textbook says to use 2 drugs, xylocaine 2% at a 7 milligram per kg body weight, ropivacaine 3 milligram per kg body weight. Anesthetists also use some amount of fentanyl and dexmedetomidine. So all these calculating per kg to come around 50 to 60 ml, 50 to 60 ml. So then we do the scalp block. So this is the most important thing to be done in an awake craniotomy. And not only for this, even for chronic subdural, doing local anesthesia, and even for craniotomy in GA, we use this scalp block. This seems to be very good. So with that anesthesia cocktail, local anesthesia cocktail, what I explained. So we inject in all these nerves, the supraorbital and supratrochlear nerves, the zygomaticotemporal nerve, auriculotemporal nerve, greater occipital nerve, and lesser occipital nerve. All these will anesthetize the scalp. So bilaterally we do this. So this causes anesthesia effect for up to 3 hours, sometimes even up to 6 hours. So once we do this, then the next step of anesthesia. So there are 2 ways we can go about in an awake craniotomy. So one is the conscious sedation, which called as awake, awake, awake. And other is a GA with intra awakening, what we call as a asleep, awake, asleep. So what is awake, awake, awake? In this patient, in this procedure, rather, the patient is conscious throughout. This is what we follow. We don't follow that asleep, awake, asleep. Here, we don't intubate the patient. We just put the scalp block, as I already told, and we start with a low dose propofol, 50 to 150 micrograms per kg minute. And the textbook says remifentanil can be given in the dose of 0.01 to 0.05 micrograms per kg. But this is not available in India. Remifentanil is not available in India. So our anesthetists use fentanyl. So this is the drug they give as a drip. So this has a very good sedative effect. But the patients can be aroused and we can speak to the patients, and definitely this is a very good anesthesia technique. The disadvantage of this is sometimes we cannot use for prolonged procedure. This is a wonder drug. This is present for the last 10 years, and this has nearly changed how we look into awake craniotomy. Because this is a very highly selective alpha-2 adrenergic receptor, and there's a very, very good sedative effect. Very good. The patient remains calm. Pain definitely comes down very well, and the patient is fully cooperative throughout the procedure. And the another main advantage is it does not cause any respiratory depression, nor does it interfere with the electrophysiological activity. So this really is a very good drug, should be used always in an awake craniotomy, especially when we go with awake, awake, awake phase. So what this means, awake during craniotomy, awake during tumor removal, and awake during closure. So all the 3 steps, the patient is fully awake. This is what we follow. So another technique of awake craniotomy is an asleep, awake, asleep. In this, the patient is intubated, either with an endotracheal tube or sometimes with a laryngeal mask airway, LMA. Both can be used for this. In this patient, what it is done is the patient is anesthetized during the initial phase of craniotomy. So once the craniotomy is over, then during tumor removal, the patient is shifted to a awake. So all the anesthetic agents are stopped and the patient is shifted to a awake stage. So then we do the whatever the tumor removal, and then after the tumor removal, again the patient was changed to an asleep. So this is asleep, awake, asleep. But here the main disadvantage is the patient is having UT2. So when the patient is awake, what happens sometimes is the patient may cough out, and this may cause the increased ICP and increased cerebral edema. And sometimes if you use a laryngeal mask airway during agitative phase, the LMA can come out. So there are different papers comparing these two techniques. One is a monitor anesthesia technique, that is awake, 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 or a awake, sleep, awake. So they say in both the results are equally good, but we follow that awake, awake, awake technique. So another thing is, even in an awake craniotomy, we can use all the modalities intraoperative. Here we are using an intraoperative ultrasound. We can use a neuronavigation. So we can use a 3-pin. So just like a routine neurosurgical case, we can use all the intraoperative modalities. But it is not always easy. Any procedures is not always easy. There will be some technical challenges, and sometimes it is difficult. In an anesthetized patient, the intraoperative bleeding may be easy to control. But in a patient under sedation or a local, it is a little bit difficult. So intraoperative bleeding is the most dreaded complication in any surgery, and especially during awake. So only large vascular tumors, better not to go for an awake craniotomy. So you should be careful in selecting these cases. So intraoperative bleeding should be managed as usual in a routine manner, and sometimes we have to use a hemostatic agents like Surgiflow. So another most important thing is an intraoperative seizure. Again, this is a dreaded complication during an awake craniotomy, and some say the incidence from 5 to 20%. This is very, very difficult because the patient is awake, the patient throws seizures, the brain is going to swell, and it is really a tough job. So what to do? So this is more common in patients who had earlier multiple seizures. So lesion, frontal lobe lesion causing multiple seizures, and the patient is already on 3-4 drugs. These patients, when we are taking a awake craniotomy, we should be very, very careful. So what to do when the patient is experiencing a seizure during awake craniotomy? So immediately what we should do is an ice cold saline or a linger lactate. And usually 80% of the time it will get settled. And always better to avoid a sedative, because if you give a sedative, then the functional mapping will become difficult. And we can give a loading dose of an anti-epileptic drug, whatever the drug we are using. And if the seizure is not controlled for more than 5 minutes, then the sedation can be increased with propofol. Conversion to GA should be decided by the anesthetics team along with the surgeons. So coming on to few papers which tell what are the common cause for failure of awake craniotomy. The most common cause for failed awake craniotomy is seizure and agitation of the patient. And next is the acute brain edema. So these are the common causes for failed awake craniotomy. So coming to last few slides. So we have a small experience of about 17 cases. And one case actually we did 2 times. That was an interesting case. There was a young man. He had a frontal speech area. He had a small tumor with recurrent seizures and speech arrest. So we told awake craniotomy. We operated. Initially, the biopsy report came as DNET. But 3 years later, he had a tumor, again, same place, tumor recurrence. So probably the first biopsy, I don't know, it was wrong. This time the patient himself asked, "Sir, do awake craniotomy." He was engineering graduate, was doing some job in a bank or something. So he was a well-learned person. So he told, second time he himself asked, "Sir, do awake craniotomy." So sometimes this happens, it will be very nice. So for a patient, we did for both times. So in all these patients, we had a gross total section except one patient. That patient was a female patient. He had a cystic lesion. She had a cystic lesion in the motor cortex, in the leg area. So we operated, we tapped the cyst. There was a cyst wall. We were while excising the cyst wall, the patient suddenly went for agitation, became restless, and the brain started bulging. The brain was just like started bulging. So what we did is we just able to take the biopsy of the wall and we closed. We sedated the patient and closed. Immediately the patient did not have any deficit. Luckily the patient did not have any deficit. But because we only removed partially the wall, within 1 month, the patient recurred with a tumor. And this time when we advised resurgery, the patient went to some other place. So these are two complications which we, and another intraoperative 5 patient totally developed mild neurological deficit, 2 had a sensory aphasia, 3 had a increasing limb weakness, but everything settled. Everything settled over a period of few days, 2 weeks. We didn't have any major complication, minor complication only, except for the one lady who I told. So this is one patient with a refractory epilepsy, recurrent seizures. So there we are using an intraoperative neuro monitoring, intraoperative neuro navigation. So after craniotomy, we're localizing. So here the patient is, so he had a left side lesion. So the patient is moving his limbs. So the anesthetist continuously monitors these. The anesthetist completely monitor the movements. So first we'll stimulate the area and the patient is having no deficit. Then we go remove the tumor in a usual micro neurosurgical technique. So while removing, we monitor the patient continuously. So this was one patient. Old age is not a contraindication. Old age is not a contraindication. This patient, some mild speech difficulty. So we did awake craniotomy for this patient. So here, this patient, we use the intraop ultrasound. But once we open the dura, we are not able to find any edematous ulcer, gyri, nothing was seen. So we use the intraop ultrasound. We localize the lesion and continuously was speaking with the patient. So we are able to do total excision. This is another patient. We had a lower limb weakness, but he had grade 3 weakness, only lower limb weakness. Upper limb was normal. So again, we subjected to awake craniotomy and we are able to remove gross total excision. This is another interesting case. This is the final slide, final 2 or 3 slides. This patient had a recurrent seizure. So CT and MRI show a cavernoma in the just front of the central sulcus. So first surgery we did with an intraoperative monitoring. So intraop monitoring, they are able to remove it totally and the patient didn't have any deficit. But unluckily, the patient developed delayed weakness. Not delayed, not too much delayed. Within 2 weeks, the patient developed weakness again. So this time when we did, there was an abscess. So this time, what we did is, we did awake craniotomy. So first we used intraop neuro monitoring under GA. This time we did an awake craniotomy. Already craniotomy was done. This time we did an awake, and we were able to remove this. So while removing slowly the abscess, the patient developed increasing deficit of the lower limb. Initially at grade 4, he went to grade 2 during surgery. So and we stopped it. But this was nearly 90%. By the time 90% of the abscess was removed. So post-op scan was also good. This patient had a drop in weakness, but later he improved within 1 month, and now he is normal. So practically, awake craniotomy decreases iatrogenic neurological injury and can improve the amount of brain tumor resection. And it can be done in any centers. What I mean by any centers? Intra monitoring, neuro monitoring is very, very good, no doubt about that. But all the centers cannot have it. And even when they have it, to get a good technician is very, very difficult. In our center, we have intramural monitoring, but we don't have a permanent technician to read the intraoperative neuro monitoring. So it is difficult. So IOM cannot be in all places, but awake craniotomy can be done even in a small center, in a tier 2 city, where they can't afford a intraop neuro monitoring. This awake craniotomy can be done. Only thing we need is a good anesthetist, good surgeon, and a good patient. So if these all three, the anesthetist, if the patient is able to cooperate, the anesthetist is confident, and the surgeon is confident, we can do awake craniotomy in any setup. So that's the thing. So definitely, awake craniotomy is the gold standard in removing lesions of frontal lobe, temporal lobe, motor cortex, speech cortex, etc. Thank you for a patient listening. Thank you, sir.
Yeah, Dr. Silva, that's a nice presentation. Very elegant. And as we had said earlier, we'll go on to the next topic, and we'll have the discussion after Dr. Veerapandiyan finishes. Over to Dr. Rajesh, please.
Thank you, Dr. Selvamuthukkumaran sir. Now we will go for this second question for the PGs from the second topic, from Dr. John Christopher's topic. Question on the screen now. Among the 4 empaneled signatories, the neurosurgeon is in which order in form number 10? That is the question. Among the 4 empaneled signatories, the neurosurgeon is in which order? That is the question. You can answer the question in the chat box, answer the questions, and based on that, we will be awarding who is coming first answer, will be given the prize. Okay, now we come to the last speaker, Professor Dr. R. Veerapandiyan. He is going to give a talk on subarachnoid hemorrhage and overview. Professor R. Veerapandiyan sir is the Professor of Neurosurgery, Madurai Rajaji Medical College Hospital, Madurai. Over to you, sir, Dr. R. Veerapandiyan sir.
Hello. Hello, am I audible?
Yes, sir.
You enable the sharing, sir. Enable the sharing.
1 second, sir.
Sir, I think you are having two devices.
Sir, it is getting echo, sir.
Sir, you are having two devices in your room, I think. One device has to be switched off.
Yes.
Now one device has been logged off.
No, still echo we are getting.
Still echo we are getting, sir.
Hello. Is it audible now, sir?
Now it is correct.
Yes, sir. Now it is correct, sir.
Now it is correct.
Sorry.
Dr. Rajesh,
Sir,
can we have the discussions on the other three topics? Meanwhile, when Dr. Veerapandian fixes up the technical issues.
yes, sir.
So, from the floor, from the audience, any questions on the previous three topics? One is the IH, second is about the brainstem death protocol, and the third one is on the awake craniotomy. Dr. Suresh. Yeah.
First to Solomuthu Kumran. Yes, Selva, it's rightly pointed out that awake craniotomy has to be done in any center. That's a good point, good valid point. Because even I used to think that why we need to do awake craniotomy in places where you have IONM and other things are available, but it's not readily available in all centers. And moreover, for like a language, I want to tell that for a language thing, even IONM is not useful. That's what the most important thing. For example, in insular perisylvian cortex area tumors, whatever the kind of IONM you have, it's not going to help much. The only thing is the awake craniotomy when you can simulate with IONM so that you can see for a speech errors or any naming problem. So that's a very good thing. I don't think for that cortex you showed that the motor thing and all those things, whether we need to use, because you have a navigation, you have all other techniques. But still, if it is you are comfortable with awake, then we can proceed. At least we are happy during surgery. That's a very good thing. I think that Veerapandian is ready. I'll just stop with this.
Hello.
Yes, sir. Dr. Professor
Hello.
Veerapandian, sir.
Hello.
Yes, sir. Professor Veerapandian, sir.
Sir, am I audible?
Yes,
Yes,
Dr.
sir.
Audible.
We can start.
Yes. My topic today is subarachnoid hemorrhage and an overview. Yes. The subarachnoid space is a potential space filled with cerebrospinal fluid. It lies in between the arachnoid membrane and pyometer. It surrounds the entire brain, dipping into and out of the surface of the sulci and surrounding cranial nerves. So actually, the subarachnoid space contains the neurovascular bundle of entire nervous system, especially the brain. So any hemorrhage into the subarachnoid space is considered as an abnormal in which the blood spreads out of the vascularity intact into the subarachnoid space. So the cause of subarachnoid hemorrhage in a clinical setting is isolated with 30 to 50%, along with the intracerebral hemorrhage in up to 40%, with the other intraventricular about 28%, with the subdural hemorrhage about 5%. So the isolated subarachnoid hemorrhage is what we are focusing on this topic. So this is the etiology of hemorrhage. The post-traumatic subarachnoid hemorrhage is the most common cause among the spontaneous subarachnoid hemorrhage, which is clinically important and surgically important, is a ruptured intracranial aneurysm, which constitutes about 75% of the spontaneous subarachnoid hemorrhage. So these are all the some of the risk factors. Age around in the 5th decade with the female preponderance, along with the uncontrolled hypertension, with other connected to disorders, with substance abuse like alcohol and cocaine, and pregnancy is one of the risk factors. So other genetically predisposing condition like familial history of aneurysm and autosomal dominant PC, polycystic kidney, and Ehlers-Danlos syndrome. So these are all the clinical signs and symptoms as far as subarachnoid hemorrhage is concerned. Among the symptoms, it is the headache, which is very classically described in any of the textbooks. This is a paroxysmal thunderclap headache. And other symptoms like vomiting, syncope with neck pain, and the visual symptoms, all it counts. So among the signs, neck rigidity with the other focal neurological deficit, with or without coma, with the subdural arterial hemorrhages. So this is the clinical grading of subarachnoid hemorrhage from grade WFNS grading from grade 1 to 5. As you all know about this grading. So this is the CT grading, grade 0 to grade 4, according to the amount of blood collected in subarachnoid and intraventricular space. So as soon as we suspect subarachnoid hemorrhage, depends upon the history and the clinical findings, you have to diagnose, confirm the diagnosis with immediate CT, which is non-contrast, is a first line of investigations in case of suspected subarachnoid hemorrhage, especially of aneurysmal origin. Lumbar puncture is not needed, not done nowadays because, and to find out the cause of the bleed, we can do other CT angio, MR angio, and DSC. In spite of all this workup, we don't find any lesions. We label it as a SAH of unknown etiology. Non-contrast CT scan has the highest sensitivity of more than 95%, which is when it is done within 48 hours of clinical suspicion. And this also can diagnose the size of the ventricle with the other blood in components and the blood in the basal cisterns with or without infarct. And also depends upon the pattern of blood in the picture, you can find out the aneurysmal location also. So these are all the CT findings in case of suspected aneurysmal bleed. Depends upon the location of the bleed, you can identify the origin of aneurysm. In case of ACOM, it lies mainly in the interhemispheric fissure, anterior interhemispheric fissure, and in the PCOM, it is in the basal cisterns, and in the MC aneurysm, it is in the Sylvian cistern. With the basilar tip, whole of the suprasellar cistern is flooded with that. So depends upon this CT finding, we can identify the site of aneurysm also. And with the 3D CT angio, you can detect aneurysm which is more than 3 millimeter in size. It is also non-invasive, and also it helps in evaluation of vasospasm, angiographic vasospasm. The limitation, it is less sensitive than the DSA, the skull base artifacts, and difficult to detect aneurysm less than 3 millimeter. So this is some of the 3D CT angios showing the aneurysm. So MR angiogram, usually it is not done in acute setup of suspected subarachnoid hemorrhage. It is less sensitive with compared to CT angio in less than 48 hours, but it can be useful after 4 days. And again, it is difficult to diagnose smaller aneurysm of less than 3 millimeter. It is useful in screening the patient for high risk for having aneurysm, especially in the history of familial history of aneurysmal bleed. It's a screening procedure in family members. So DSA is a gold standard technique. It detects even the smaller size of aneurysm. To study the vessel of highest suspicion first, depends upon the finding in initial CT. It also demonstrates the source of aneurysm or AVM in 85%. So remainder are so-called, I said already about SAH of unknown etiology. It also shows if there is any radiographic vasospasm also. So this is some of the DSA picture, which is showing the aneurysm. So management of ruptured subarachnoid hemorrhage in case of ruptured aneurysm. This is the outcome of ruptured aneurysm if it is not treated. Up to 15% die before reaching the medical care, 10% die within few days, and 50% die in 2 weeks. Other people have severe disability and morbidity. Causes of morbidity is the rebleeding. Risk is up to 20% within 2 weeks, and 25% of the systemic complication like pulmonary edema and stent myocardium, and other vasospasm up to 7% and 8% up to the progressive deterioration from the initial hemorrhage. So this is the management protocols for ruptured aneurysm. First you have to prevent rebleeding. You maintain the cerebral perfusion in the basic setting of increased intracranial pressure, and also you should reduce the brain edema and intracranial pressure. Of course, control of seizures and vasospasm with the concurrent management of any hydrocephalus, it is there, and other secondary complications like fluid and electrolyte imbalances and others. Maximum time of rebleeding is the first day within first 6 hours. The optimal management of early intervention to prevent rebleed is early intervention by either clipping or endovascular coiling. And then so these are all intraoperative ECG. Clipped aneurysm with intraoperative ECG. So to prevent rebleed, again, you have to first you clip the aneurysm or embolize, coil the aneurysm. Triple H therapy, typical of it shows you maintain the systolic BP 120 to 160 so as to maintain the cerebral perfusion pressure, and then use of calcium channel blockers, maintain the euvolemia, seizure control and prevention with antifibrinolytic therapy. Again, it is the maintain the cerebral perfusion in presence of increased ICP, so that you have to maintain the mean arterial pressure of more than 70. And then to increase the blood rheology, you have to increase the blood volume by maintaining the hemoglobin more than 30 PCV or hemoglobin 9. Of course, with the brain edema, you can treat the brain edema and with the mannitol and the 3% saline. Other, if patient is having progressive hydrocephalus, you can go for EVD with ICP monitoring. These are some of the EVD procedures which you commonly use. And then for seizure control is important because it worsen the clinical outcome and also more cause for morbidity. So these are all the risk factors associated with the seizure. And then you can use all other anticonvulsant drugs like phenytoin, sodium valproate, and levetiracetam in appropriate doses. You have to treat the patient with a prophylactic anticonvulsant. So short notes on vasospasm, which is cause for delayed neurological deficit, can be a clinical and angiographic vasospasm. It starts 3 days and lasts up to 14 days. So clinically, patient may be drop in sensorium with raised ICP features, with the focal neurological deficit freshly developing. We should suspect the vasospasm with infarct. And the subarachnoid hemorrhage with the hemoglobin breakdown products causes neural cell membrane lipid peroxidation, and then calcium release, which causes vascular smooth muscle spasm, which is causes vasospasm. Triple H regimen to prevent or management hyperdynamic therapy, nimodipine and other medications. And then chemical angioplasty, endovascular injection of nimodipine, verapamil, or endovascular balloon angioplasty. Hydrocephalus, hyponatremia, you have to think of hyponatremia, especially in a patient with a deterioration either in the post-operative or post-coiling period. You have to treat accordingly, maintain the sodium level. Systemic complication like neurogenic pulmonary edema and neurogenic stunned myocardium, you have to treat accordingly. It is predominantly a part of the intensivist management at the post-operative ward. And then you have to anticipate arrhythmias, and you have to be ready with that also. Other complication, of course, we have to think of, and we have to be cautious about it, which can also cause morbidity. So in our study in Anna Joseph Hospital, number of cases of 45 with over a period outcome assessment 6 months, with the good functional outcomes of 73%, with the mortality of 18% on par with any institutions. To conclude, the essential management of subarachnoid hemorrhage is to prevent the vasospasm, prevent the rebleeding, maintain the cerebral perfusion pressure, by triple H method, and also early aneurysm clipping or coiling is recommended rather than waiting for the period of vasospasm to go off and then delayed surgery, because it sometimes it will be very difficult to dissect arachnoid membrane adhesions. So early surgery is recommended for better outcome. Actually, this team approach consists of neurosurgeon, neurologist, interventional neuroradiologist, the critical care specialist, and neurorehabilitation with neuropsychiatry. Thank you. Thank you so much for patient listening. Hello, sir.
Thank you, Professor Veerapandian, sir.
Thank you, sir.
Now we will have the third question from Dr. Selvamuthhukumaran Stock. On the screen. Who performed the first awake craniotomy in India? Who performed the first awake craniotomy in India? That is the question. So now we can have the question session now.
Dr. Suresh,
Yeah, I'll just.
you're talking about awake craniotomy. Yeah.
So thank you. Actually, very nice presentation, Dr. Veerapandian. I'll come to your presentation later. Regarding that awake craniotomy for Selvamuthhukumaran, we can go in a middle path. What we did is, like we use propofol and dexmedetomidine. So give a deep sleep initially, then wake him only with the dexmed, then again with propofol sleep. Instead of putting an endotracheal tube or a laryngeal mask, we can do that.
Yes, we use that only. We don't use endotracheal tube.
That's what, because you are telling awake, asleep, sorry,
Yes,
sleep.
usually we use only awake. Propofol
you-
and dexmed. Textbook says two methods are there. Both are good. Textbook
Yeah.
literature says, but what we follow is that awake.
Yeah.
We don't
But what
intubate the.
we do asleep, awake, asleep, but in that we don't use endotracheal tube. That's what I'm
Okay,
We can
okay.
That's a good thing. Even
Okay.
that went on well. That's why it's a good.
Yes. Okay.
Thank you for Magesh talk. Just a comment. Very nicely presented. And regarding that, what is that? Optic nerve fenestration. Of course, he told it should be in the experience, and that's correct. Instead of a lumbar peritoneal shunt, if we try to do VP shunt, that solves all the problem, because lumbar peritoneal shunt only like cerebellar, tonsillar herniation, all those things. So with the neuro navigation, almost all patients can go for a VP shunt if surgery is indicated, so that we can avoid that optic nerve fenestration at all. So far, maybe in the initial period, I did the optic nerve fenestration. Nowadays, only VP shunt if indicated case only. Of course, like any patient improves with the post-lumbar puncture, that's good. We need not do anything. But otherwise, it's a very good overview. It's a for that for us, it's a very good revising the subject.
Thank you.
Dr. John's talk. Anything, Magesh? Any comment on it?
I'd like to read your point only, sir. Going for surgical intervention might not be required in the majority of the cases. Like going by our experience, though it may be numbers may be less, 100 or even less. But then we find a majority of patient losing to follow. That means that they are getting treated. They don't come back.
Better. Yeah.
So there are few cases which do worsen in spite of interventions, and few cases are there that probably make less than 10% or so. Should be.
Yeah. Why I was telling is, initially when we study, they used to do only lumbar peritoneal shunt.
Yes.
For the thing, because maybe because we don't have neuronavigation that time, it's very difficult to cannulate. But now almost all cases, so far I am successful with neuronavigation, but most of the time I try blindly. 95% it's okay. Only 1 or 2 cases we try. We have to use the neuronavigation, but neuronavigation will be ready for all cases. That's why we can proceed deep vision first of all. Why I'm telling is most of the neurologists don't believe that. They just refer only for LP or
Exactly.
that optic nerve penetration. If you tell deep vision, they think that deep vision is a easier procedure. They don't know lumbar vision. That's what I have to convince them that, that's what to do. Thank you. Very nice presentation.
Thank you, sir.
Dr. John, just one question for you, because is it okay for us to do brainstem, what is that, confirmation even without a patient knowledge?
No, sir. We have to get consent even before first apnea test.
Okay, because why my understanding was brainstem certification we do only when there is a intent for organ donation, but you told it is otherwise. There is no need.
Yes,
for,
sir.
but only thing we have to get.
Yes, sir.
Sir,
But all these
the-
myths are there. According to Act, you can do even without organ harvesting.
Only thing we get a consent from the relatives.
Yes, yes,
So
yes.
that's a good thing. It's a new point for me, really.
Sir, I'd like to.
Sir, I would like to interfere in that.
Yeah.
Actually, it is not, consent is not required, sir. Actually, in case we are doing it regularly, all patients we used to certify brain death. After that only we will inform the patient attender.
Correct, sir. As per the law, the consent is not essential for proceeding with the brainstem death certification, sir.
Okay.
It is legal. We need not get the consent, and
So actually,
even we
it is
can
not-
even proceed with this second apnea test. Even the question is the patient or attender is not willing for organ donation. Our idea is only to, as a treating surgeon, our idea is only to prove that any further treatment is futile and doomed. And I'd like to differ with one point which Professor John has said. He said actually as per the GO number 6, it has been made mandatory all over Tamil Nadu, especially of the centers in Chennai. And as the GO was passed as early as 2008, and it made mandatory to certify brain death. That was one point to make available the organs, and the second was to make the available resources free for some other more deserving patient. And what is said was, we can take off, that doesn't mean we can remove the life support systems. Please mind, do not resist it, is not legal in India. Even all the intensivists and all the anesthetists whom we move along are based on the UK curriculum, which says DNR. Though we get it signed from the relatives, we are not legally bound to remove any of the life support system, at least on paper. And we are liable to be charged under culpable homicide not amounting to murder when we are willfully doing it and documenting it. That is more important, sir. We are not supposed to remove any life support system. Suppose a patient is not willing for organ donation, we have to maintain him till his biological death. No other go about it.
Sir,
But what
one
about the
interjection, sir.
patient wants to withdraw?
So actually, actually it is what happening nowadays in Chennai. Actually, we are routinely doing brain death certifications. Almost every day we are getting one case in Kilpauk Medical College. We initiated this program just last 4 or 5 months back. Now what we are doing, like Magesh said, actually then John Christopher's lecture is a very good point. If you are certifying brain death, that means patient is dead. So there is no point in continuing the treatment. So you can certify death that time itself, but you cannot withdraw the support as per Indian law. Like Magesh said, so you have to continue till the patient dies. There is a controversy arises in each every case in our hospital because physician they don't want to discontinue the treatment. But if the attender says we don't want to continue the treatment, you can disconnect and get signed from the attender. Otherwise, you have to continue till death. But as per our brain organ death act, it says that If you are certifying second brain death, that means the patient is dead. That is the time of death.
Oh, okay.
Sir, one
Time of
interruption,
death.
sir. Sir, one
That certificate
interruption,
also
sir.
that will come. That certificate also that the second
Will come
apnea test
under-
time will come.
Yeah,
Yes,
second
yes.
apnea
Second
time
apnea
is
test is the death time.
That time.
Yes,
So even
right.
when the organ is retrieved
Actually-
6 hours later, the death certificate, the time will be the
Yes.
second apnea test.
Yeah, there is a lot of confusion in this. The second apnea test time is the death time.
Yes.
Correct. Correct.
Sir, one
Correct, sir.
interruption, sir. We are going to give the fourth question for the PGs. Naveen,
Sir, doing. So 1 second, sir. Please be online once again. Yes, sir. Now it is ready. Yes, sir. Now it is ready.
It's not here, not displayed.
question has not come.
1 second, sir. 1 second. Ah, it is come, sir. Now. So now it is featuring, sir.
Yeah.
After aneurysmal rupture, when will the cerebral vasospasm will be at the peak on which day? After aneurysmal rupture, when will the cerebral vasospasm will be at the peak on which day?
I think we'll continue our discussion.
Okay, we will continue our discussions.
Question to Dr. Selva.
Yes.
Selva, this is regarding, do all your patients for awake craniotomy, do you put them on pins or do you keep on horseshoes sometimes?
Sometimes pin, sometimes horseshoe. Depends.
How many of those cases you need to convert to intubation and procedure?
No case. One case actually I told no one female patient,
Right.
we aborted the procedure. We took a biopsy. So we finished, we closed the only thing is because we only took a biopsy within 1 month recurrence came.
Right.
So that time the patient was not willing for surgery. We do again.
We need one of the comments
Kidney
saying
is always comfortable, sir, in awake craniotomy. Instead of horseshoe, if the
Yes.
patient moves while doing surgery, it will be very uncomfortable. So always fix with 3 pin and sedate the patient.
You need an excellent anesthetist, a good neuroanesthetist.
We have excellent
you.
anesthetic.
Otherwise, if they are little on the verge of a little dilemma.
Yes, I think awake craniotomy, because technically microneurosurgery is the same. Only thing is anesthetist has to be very good.
Very good, yes.
They should be confident. Rather, they should be confident.
Question
Actually,
to,
according to
yeah.
related to Magesh talk, sir, we have done so many LP and CSF dynamic studies with Dr. Magesh. Actually, more than around 100 to 150 patients in idiopathic intracranial hypertension. Nowadays, most of the patients, 95% of patients settle with diamox. The surgical indication is coming down drastically. Most of them will have some of the factors like anemia. If you correct anemia and start diamox, almost 95% of the patients settle with medical treatment. That is my personal experience. I don't know. I want some opinion from others.
Thanks, Professor Kodiswaran, for the acknowledgement. And a word of caution there for MJS's account on fat fertile female 40. We do see patients who are non-obese, lean, and males. So just a word of caution, sir.
Dr.
Not
John,
clear, sir.
Dr. John,
Yes, sir.
question to you. See, sometimes during nowadays we don't do this brain death protocol here. But it is in our during our PG times and then in Vellore, we used to find when you're doing the apnea test, already the patient is on 20 supports and so on in kind of head injuries. When you try to take off the ventilator and put them on a T-piece oxygen, most of the time the BP tends to fall. It goes to 60-40 and then we reconnect to the ventilator. Do you face such situations? In that case, what do you do and how do you go about declaring on apnea test 1 and apnea test 2? And how we go about in this kind of cases where the patient is not stable, they go down on the pressure the minute you take off the ventilator and put them on T-piece.
My personal experience is 2 or 3 cases, same thing happened, like what you said, sir. Same thing happened. Hypothermia and BP falling, hypotension, everything happened. For last 2 cases which successfully done, I just given adrenaline infusion. That's an excellent cardiac stimulant, and it is keeping the heart rate, maintaining the BP and hypothermia, able to maintain the body temperature, everything. This one advice, someone previous neurologist gave this suggestion. I tried it. Because nobody use adrenal infusion nowadays, mostly noradrenaline and other costlier things only. But this adrenal infusion very effective, and kidney organ also we harvested in very good condition, and the recipient organ immediately started functioning, even better than live transplant. So I suggest this adrenal infusion in that case very effective.
Yeah, because
We
most of
use
the time,
vasopressin and adrenaline. We use
vasopressin.
Yeah, vasopressin can be maintained,
and,
but the short course of
adrenaline.
adrenaline is very effective.
We use vasopressin for these type of cases. We use
Vasopressin
and
and
times
noradrenaline is a routine case, but not maintaining that much compared to this adrenaline.
we also use adrenaline in certain cases. As Dr.
Okay,
John
okay.
told, we use adrenaline in certain patients, especially in these brain dead patients. We use.
Yes.
Any other questions or comments?
Pandit sir is there, Dr. Veerapandit? Not around. Okay, just a comment on this thing. Nice talk. The only problem regarding no, boss.
Hi, boss.
In your talk, very nice overview. That's a very good. I like a revision. Only thing that lumbar puncture, you told there is no need. But what it means, unfortunately, most of our patients, they may come late with a headache. They just treat locally. Come after a week or 2 means, if we really suspect, we have to do lumbar puncture and do send for a xanthochromia. In mostly in UK, that's what I learned there. The people come after the post-coitus. They just come and tell there's a big headache. They take it. They don't take it seriously that time. But after a week or so, they just come to us. That time we do lumbar puncture. We found many subarachnoid haemorrhage patients with xanthochromia. Of course, in India, we are not practicing that much. But if there is a real suspicion, we have to do lumbar puncture because most of the time CT will be normal, MRI will be normal. So we don't find any blood. If we don't find any blood, we don't investigate DSA or anything. So LP is useful. And for exam purpose also, that's useful. Thank you.
Again.
Hello, Dr. Veerapandian.
Yes, sir.
Dr. Ganesan, Madurai, surgeon.
Sir.
How are you?
Hello, sir.
Very happy to see you.
Thank you, sir. Thank you, sir. Thank you, sir.
I used to listen to all Zoom meetings.
Thank you, sir.
Okay, very nice to see you, sir. How are you, sir? There. Nice presentation. All the presentations were nice. It's really, as a surgeon, we should know certain things. We should not only be doing only on the operative side, we should know the other side also. Thank you so much for the organizer, sir.
Thank you.
Thank you, sir.
Any other questions from the PGs, from our professors?
I think all are tired, sir.
So So actually today the Tamil Nadu Medical Council observer was Dr. Ramesh Duraraj from MMC. He was the observer, and I think he might have come and gone. Dr. Ramesh Duraraj is a radiologist actually from MMC. And actually we have got the 0.5 credit hours for this meeting. And actually from the year 2012 to 2022, we are supposed to have 60 credit hours. That is the thing. So all of you, please enter your name. It is not entered, along with your email ID and the registration number. And now we will go for the question answer session. And the winners will be announced now. The first question was Dr. Mahesh sir. What is the maximum tolerated dose of acetazolamide? Mahesh sir, answer பண்ணுங்க sir.
Sir, up to 4 grams per day has been
4 grams per day is the answer. And the winner is Dr. Naga Vishnu Shankar. First prize for the first question. Dr. Naga Vishnu Shankar is there? Hello? Dr. Naga Vishnu Shankar is there?
He is my PG only. I will inform him. He is my PG.
Dr. Naga Vishnu Shankar is on screen now.
Yeah.
Congratulations, Dr. Naga Vishnu Shankar. You are very smart to come with the answer. Congrats. We will give you the gift check for 2,000 rupees. Next, the second question. Among the 4 empaneled members, the neurosurgeon comes in which category? Which number of the 4? 1, 2, 3, 4. In
There
which
is
number?
Number third.
Number 3 is the neurologist.
Third signatory.
That is the answer. And the winner is Dr. Jayachandran. Dr. Jayachandran is there?
Hello.
Yes.
Yes, sir.
Congratulations.
Thank you, sir.
Introduce yourself.
Sir, neurosurgery first year PG from Tirunelveli Medical College, sir.
Congratulations.
Thank you.
Thank you, sir.
Now the third question is Dr. Selvam Muthukumaran's question. Who performed the first awake craniotomy in India? Unmute, Bala. Selva, unmute. Selva, unmute.
Professor B.K. Mishra.
Professor B.K. Mishra. And the winner is Dr. Tamil Anand. Tamil Anand is from which institute?
Meenakshi Mission. Sadi நடந்துச்சா?
Tamil Anand. Tamil Anand, introduce yourself.
Dr. Tamil Anand from Meenakshi Mission Institute, Madurai.
So, congratulations. You have won the prize for this question.
Thank you,
Professor. And now the last question is, fourth question is, after the aneurysm rupture, when is the cerebral vasospasm will be at the peak? On which day? That was the question. From the answer which Dr. Veerapandian sir given, the answer is 7th day. Actually, it's given. And the winner is actually, is not mentioned the name, so iPad, and it is Dr. C. Nikhil Kumar. Dr. C. Nikhil Kumar is there? Nikhil Kumar is from which institute? Dr. C. Nikhil Kumar. Huh? Hello. Dr. C. Nikhil Kumar is available. Dr. C. Nikhil Kumar is the winner. Congratulations, Dr. Nikhil Kumar. So, any other questions or any other doubts? We are going to give the certification like this for all the winners who have done it. And for the speakers also, we will give the same type of a certificate for the speakers also for giving a talk in this meeting.